Hello and welcome to the Print Soft Cover. I am Sumi Sukanya Datta and today we are going to talk about this book, Managing Chronic Pain. The book is an attempt to uncover the mind-body connection of chronic pain and show us how its mental and social processes cannot be separated from the physical. So we have with us the authors of this book, Dr. Vandana V. Prakash, and she's a clinical psychologist, and Dr. Mary Abraham. She's a veteran in neuroanesthesiology, pain and palliative care. Thank you so much for being here with us on this show, ma'ams. And so I would like to know first, you've already written a book about chronic pain. This book was titled Conquering Pain, How to Prevent It, Treat It and Lead a Better Life. So why this book now? Why did you feel the need to, sort of with a related book?
See, the first book, Conquering Pain, it is more in general about all kinds of pain. Pain has been distinguished into three categories: acute, chronic and cancer pain. Okay. So we have tried to cover everything in the first book. But this book, which we have written about managing chronic pain, this is primarily focused on chronic pain because it has got a very strong psychological and social bearing as well. Mm-hmm. Whereas pain normally is thought only in physical sense. So this is what we have tried to bring out in the book.
Okay. Ma'am, your thoughts on this?
You see, the acute pain, which we had covered in the first book, is something which is a temporary phenomenon, like for after surgery or after a trauma, accident or a sprain. So it usually goes away in about maximum 12 weeks, even earlier sometimes. So it's limited. And its treatment is also much easier. They respond to anti-inflammatory drugs and painkillers more readily. Chronic pain is a different ball game altogether because this is a pain that is lasting more than 3 months. It can also include chronic non-cancer pain or chronic cancer pain. Mm-hmm. Cancer pain also can be chronic. And prevalence, it's nearly 20% worldwide of chronic pain. And the problem is it's
as
more
in 20% of the people have
chronic pain. Yes.
Oh, that's a huge number.
Yeah. And it's more difficult to treat. And in fact, the original injury may be masked, and so it is no longer a symptom of a disease. The pain is no longer a symptom of a disease, but becomes a disease in itself in chronic pain, unlike acute pain. So and with so much of psychological and social repercussions, that when we see patients with chronic pain, we need to delve into their, not just look at the physical part, but we also have to delve into their psychosocial aspects also. Because if you don't treat that, it's very unlikely that that pain also will get treated easily. So that is why we have to look at it from a biopsychosocial perspective, which is more relevant in chronic pain as compared to acute pain.
So are there any specific types of pain that you can call chronic pain? Which are the people, which is the gender which is most affected by it? And also what are the ways of, managing
See, chronic pain in 2019, the World Health Organization has this ICD-11, it was brought out, in which for the first time they classified chronic pain.
Okay.
This was maybe just 5 years ago, right? So they classified it as chronic primary pain and chronic secondary pain. In chronic primary pain, there is no disease as such, like fibromyalgia, psychological pain. There is no underlying organic cause, but the pain is there. So that is being classified as chronic primary pain. Whereas chronic secondary pain, you have a whole lot of conditions, like chronic secondary musculoskeletal pains, chronic visceral pain, chronic neuropathic pain, chronic headaches, chronic post-surgical pains. So a lot of those pains have now come. So with this classification, it makes a little more sense.
Like this book also touches upon how to, manage such pains, specific types of
we have got a whole chapter on that, on management of pain. And we have covered all the things, whether it is the medical, like what kind of drugs can be given, interventions can be done, physical physiotherapy, even CAM methods, which is complementary and alternative methods, then psychologically, which therapies are effective with patients who have chronic pain, and even social therapies, like how it helps a family. If one person is a chronic patient, it affects the entire family.
Right.
So, and luckily for us, we still are family oriented people in our country. So the family dynamics gets quite disturbed when there's a patient at home. So many times we see marital disturbances are there, the ambitions of a person are not there,
And the caregiver
caregiver stress is there. Then so many times a person leaves or cannot work anymore, so somebody else has to take the mantle of running the household and all. So the dynamic, we see a shift when there is a chronic pain patient at
And
home.
there's another thing we also look at, besides what Vandana said, many of these patients are overweight and obese. So when I see a patient coming who's overweight and obese, then we even counsel them on their weight and the kind of nutrition they should take, control their diseases, like they may have coexisting disease like diabetes or thyroid problems or osteoporosis. So these can also contribute to chronic pain, vitamin D deficiency, B12 deficiency. So we look at it from a very holistic point of view, and we tell them that, unless you reduce your weight by taking a proper diet, we explain about the kind of diet that they should take. See, that also comes under purview.
Okay.
It's not
all there
just
in the book as well.
focusing.
Yeah.
We are looking beyond the disease at the person.
Even nutrition, like it also affects how much of inflammation is there in the body, especially in conditions like rheumatoid arthritis. So the inflammation is there in the body. Certain kind of food also increases.
There are pro-inflammatory foods and
Foods,
anti-inflammatory foods. So we
So this
counsel
is
on
also-
that also.
Okay, all that has been touched
Yeah,
upon.
yeah,
in
We
this.
have touched upon
Touched
that
upon
in
in this book,
the book
yeah.
also.
So in our country, when it comes to pain, there is a sort of, sometimes people have a sense of resignation or acceptance to it, because suffering is seen as a way of maybe connecting to God. So do you, in your experience, come across such patients? If yes, what are the ways do you advise them or guide them? What is your outlook towards such?
There are lot many
Thought.
patients who come with this, and they do feel as if they've committed some sin, so they're being punished for this. And the pain is just a way of, saying to God, okay, now you punish me and I'm willing to bear the punishment.
In fact, the word pain is
Pain,
derived
yes.
from the Greek word poine,
Which
means penalty
punishment.
or punishment.
Yeah. So in such cases, of course, we do therapy with them. We do tell them there are ways of getting better, and there are ways of getting better. There's no doubt about that. So definitely therapy helps a great deal with these people, and especially guilt feelings. If there are guilt feelings, we have to deal with that guilt feeling during the therapeutic process. In fact, I had a patient, who had cancer, and he was part of the Kargil war. And for him, he kept saying that because I've killed so many people, God is punishing me now, by giving me this kind of pain in cancer.
And the other spectrum is people say that, why am I suffering so much pain? Why did I get cancer? Why am I suffering pain? I've always been good to people. I've always done good in my life.
So there is
Why
one
is
this
God-
kind of patient and then
Yeah.
Yes.
And why am I existing? Existential issues also come.
Yes.
So this is the whole concept of total pain. So what is total
This
pain?
is what is called spiritual pain, what Dr.
So
Mary
in
was
total
describing.
pain, we have the physical part, the psychological part, the social part, and the spiritual part. This is a concept of total pain. It was initially for cancer, but you can now even extrapolate it to non-cancer chronic pains, not acute pain. It was Dame Cicely Saunders in the UK, who was the pioneer of palliative care, who mooted this thing of total pain, in which she described that there is a spiritual pain also. So we need to address all the facets of that, not just the physical part. Occupation, social, worries about their children. When I go, what will happen to my family? That's also a pain, social pain. And of course, psychological, Vandana can tell so many aspects of how it affects the psychology of the patient.
So when it comes to pain management, is our approach, what we adopt in India, different from how it is done in the West? What are your experiences?
Definitely, there are a lot many differences. I think let Mary first describe about the medical aspect. This is very important.
See, like I told you, there is no magic bullet to treat chronic pain. Unlike in acute pain, you give anti-inflammatory drugs, you give a painkiller, the pain gets better and it comes down over the next 3-4 weeks, it's gone. In chronic pain, it's very different. So we, since there's no magic bullet, we believe in a multimodal kind of treatment with multidisciplines involved. Because pain itself is biopsychosocial, so it has to be multimodal. So in multimodal, what we need to treat the body, we need to treat the mind, and we need to treat the rest of the problems that are emanating from this. So when treatment of the body is concerned, there are a whole lot of medicines that are available. With so much advances, now we have got drugs that are relatively free of side effects. But even that, we have to use it very cautiously, keeping in view the comorbidities of the patient. If he's a diabetic or, you have to be careful while giving drugs. Then there are interventions that you can do, which can be starting from dry needling to actual pain interventions, which are guided by, earlier we used to use these interventions based on landmarks. We used to feel the bone and then mark the site of injection. Now we are doing everything guided, either X-ray guided or ultrasound guided. It has greatly increased the safety and accuracy of these injections. They are called pain interventions. So there are a whole lot of ways in which we can treat by medicines and interventions. Besides, we focus on physical therapy, exercise, losing weight, nutrition, etc. So this is the part of the one aspect of it. That is the treating the body. And then the treating the mind, I think, then I'll be able to tell better.
Yes. See, in the West, one of the things which we notice is that the family system is not very strong. In our country, we have a very strong family system. Like the support system is much better. So we also involve the families when we are treating patients. And they're like extended therapists at home when we are treating patients. Apart from doing whatever psychological methods that we need to, especially like cognitive behavior therapy, one of the things which we find with chronic patients, there's a lot of catastrophizing thoughts in their minds. They always think the worst of everything. There's a little tingling in the sensation of, in the body. They start thinking, okay, is it cancer developing? Is this thing happening to me? Will I die? So these are catastrophizing thoughts. These have to be dealt with. And as we are treating, this is done mostly by using cognitive behavior therapy. It's a very, very effective method where we change the negative thoughts to positive thoughts. So this helps. This is where the family, when it rallies around the patient, it helps a great deal to treat the patient much better, which we do not find in the Western world. Because the family system, the values are very different from ours. So this is where, in fact, even morphine, the amount of morphine which is given there, or any kind of such drugs which can be very, very harmful, and a person can become dependent on it. These are things which are done very cautiously in our country.
See,
that's a major difference between them and us.
So it's more of a cultural
yes.
And we are very hesitant to use these strong opioids for non-cancer pain. We are using it for cancer pain and must be done if the pain is very severe. But in non-cancer pain, we very rarely use these strong opioids. And this is being used so much rampantly in the West that there is what is called an opioid epidemic that's happening there. And you won't believe, in 2023, I was just looking up the stats. In 2010, it was 10,000 deaths. And in 2023, it is 1 lakh deaths. So the COVID pandemic has caused actually an upsurge of these deaths. Every month, there are 300 deaths.
Happening. You're talking about the US.
Every day there are 300
US,
deaths
Canada,
happening.
These Western countries, where
because it's being indiscriminately used over there, So thankfully, we have not reached that stage. Because we have got very strict rules where these narcotics are concerned.
In fact, I'll come to that. That's also something.
And other things like yoga, meditation, all these things also help a chronic pain patient.
Yes, I was coming to that
Ayurveda,
also. You know, for
Ayurveda.
instance, though there is a debate going on how effective, how scientific are these traditional ways of medicine, but being pain specialists, both of you, what do you think about usage of traditional medicine, especially yoga, Ayurveda, homeopathy for pain management?
It's very useful as an adjunct to our mainstream medicine.
Yes.
Okay, like I have a patient who has got very severe sciatica. So I'm giving him treatment. I'm doing dry needling for him, but he's also doing yoga. In fact, he brought his yoga teacher and said that, please tell me what yoga they're doing. Are they okay for my back? So many of our yoga exercises, if used in the proper way judiciously, it can be as good as exercises. So they definitely have. So these non-pharmacological therapies like yoga, meditation, they do play a very important role in addition to your mainstream medicine.
There's a concept called supportive psychotherapy, where various kind of things are used, especially like dance therapy. Okay. So a person may be sitting on a chair, but you make the person, with the music, you make the person, move about. So this increases the movement, especially people with a lot of muscular problems, right? So it benefits them. Or we have things like ventilation. You just pour your heart out to somebody, and just, even if the person is crying and all, we just let them do what they want to at that point. So let the emotional upsurge go away. It helps to heal a person a lot.
I can tell one example. I had a young lady, middle-aged lady. She was my colleague actually. And she said, I've got very severe pain. She was looking for me. Please do something about my shoulder pain. So while I was just asking her history, she mentioned that 3 months ago she had lost her mother. And she said, Dr. Mary, I never cried. I never let out my grief. And having said that, she just burst into tears and just cried and cried. And at the end of it, she said, I'm feeling so much more better.
Yes.
That bottled up grief, that like a pressure cooker.
That sort of also manifests
that venting.
itself.
And then of course I gave her the treatment, but after that she recovered so well after that. But that bottled up grief had to come out. It's not a good idea to, saying that I'm strong, I'm doing it for my mother.
Suppress your feelings.
Yeah. It just translates into the body, and the
remember,
body gets affected. Like
people
she had that severe pain.
Chronic pain are very sensitive people. So even slight, you don't smile at a person, don't look at it, but they feel very hurt about it. And they carry these hurts within themselves. That is where therapies help a great deal, letting go of these things. And looking at the positive side that yes, you have certain things which are still good, which is acceptance and commitment therapy, which we use. You have a problem, accept I have a problem. But it's like, the cards which are dealt to you when you have to play a card game. This is what I have, so why not utilize it? This is the positive aspect of it also.
You don't allow that to affect your goals in life.
So with your pain, you still do what you can still. Whatever your capacity is, still continue doing that.
Yeah.
That
don't
is
stop
what,
because of...
Yes.
So you're defocusing your mind, taking it away from the pain and focusing on what you
something
have to
else.
do.
Right. That's very important.
Especially cherished goals, whatever you have.
So we already talked about it a little bit, but now a little. I would want you to please elaborate a little more on this. Like you said that in India, for instance, there is it's very tight regulation around the painkillers, especially for cancer patients. Opioids, for instance. Do you feel, because so much so that some people who actually need it sometimes struggle to get it? There is this whole parallel sort of movement or effort going on to make these sort of drugs, pharmacological interventions, more accessible to such patients. Do you, on the policy part, do you feel the need, because both of you are working in this area, to be the regulations, the policies be more patient friendly, or do you see a chance of abuse?
Been done.
Yes.
See, the original act was passed in 1985, the Narcotic Drugs and Psychotropic Substance, NDPS Act.
Yes.
So with that very stringent laws, and lot of regulatory bodies were involved in that. Okay, and as a result, and of course the punishment was very severe, heavy fines and even jail. Okay,
Yeah.
so if anything was violated, so even the pharmacist was hesitant to keep it, hospitals were hesitant to keep it, doctors were hesitant to prescribe, and patients were hesitant to take it. Hesitancy all through. Then a lot of people worked because they found that cancer patients, when WHO in 1986 made the WHO step 3 ladder, in which they legitimized the use of morphine and strong opioids, because the step 3, which is for severe pain, is treated with strong opioids. So the WHO, by introducing that ladder in 1986, actually legitimized the use of opioids. Subsequently, a lot of people worked all over, and in India, an amendment was carried to that act in 2014. With that amendment, it became so much more easier to procure these strong opioids, because now it's only the drug controller who was the authorized person, and he would recognize institutions, whether it's institution or any body. It's called recognized medical institutions. They are permitted to store these opioids. So now you have a form called a DD-12 form. You have to fill it up. You have to write your name, patient's name, address, your stamp. And if you fill that prescription and go to any registered medical institution which has been licensed to dispense these drugs, the patient can get it. So now there is not much problem where
In accessing
procuring these strong analgesic for severe cancer pain. And that started with that 2014 amendment to the NDPS Act.
Yeah. So now I would want Dr. Vanna, if she can tell us, and then you, ma'am, on why do you think, who will read this book and why? Is this just chronic pain patient who will want to read this book, or it's for everybody? What are your thoughts?
I think it is for everybody, simply because Lord, there are, as I said, so many people who have chronic pain. 20% is a huge amount. Also, incidentally, world over, depression is also 20% all the time. Okay. One of the symptoms of depression is pain. And depression and pain actually go hand in hand. They are very strongly related to each other.
That's very important.
Secondly, people who are the caregivers must read this book also, simply because they will understand the psychosocial aspect of it. Apart from the physical, they're already seeing a person in pain. But when they understand mentally what a person goes through, perhaps they will understand the patient better. And there will be more harmony in the family. One of the things which we have written in the book is about expressed emotions. This is the hostility which develops in the family itself against the patient. The patient is not doing enough, not getting up, becoming a burden, not eating, and all kinds of criticism for the patient, which of course is difficult for the patient also to handle, and they tend to become more chronically ill because of this. So understanding the psyche of a person is very important.
So how to maintain the positivity despite the circumstances.
Despite the circumstances.
Yeah.
Right. And of course it is meant for clinicians also. Any person who is into pain management will find this book very, very effective.
Yeah.
Actually, there is a lot of lack of awareness about the existence of pain specialists, palliative care. There are so many people who call me saying that, my mother has stage 4 cancer. Where do I go for palliative care? Some people have not even heard the word palliative care. They don't realize that there are pain specialists now available. So there is a lot of lack of awareness in our country, and we need to improve it. And our effort writing the first book and now the second book is just a small step to increase the awareness.
So, yes.
And it is written in such simple language, not too much of medical jargon, so that every person can understand what is written in it. And
again, remember, this is still limited to the educated public, and again more to the metros, bigger cities than in the villages.
Yeah.
We have yet to reach the villages.
See, 2/3 of our population live in rural areas. They have not heard of pain doctors. They need to go such long distances even to access palliative care. So we wanted to promote awareness by writing such books.
In fact, if you see in the villages and all this, since they do not know what is palliative care, the person is just left to die, you know, whatever they can do.
Absolutely. That's really sad.
It's very sad. That kind of scene, when we see patients coming from villages to the city for treatment, that is how we get to know that it's a very dismal situation.
And
there.
you know, this now under the right to health, the World Health Assembly in 2014 said that it is the moral obligation of every doctor to provide relief from pain. It's part of the right. In fact, not relieving pain is deemed cruel.
Yeah.
And it's a patient's right to receive pain management.
In fact, this is the fifth dimension to medicine now.
Yes. And the WHO has said that palliative care should be integrated to the primary health care level.
In fact, every hospital should have a pain clinic, you know.
Yeah, which is not there in many. Yeah. Anyway, so thank you so much, ma'am, for being here with us, and all the best for this book. I hope that every viewer who is watching this show goes and picks up this very important book, and all the best. Thank you so much. Thank you for watching.